Introduce John. John Meeker is an associate professor of environmental health sciences, and he's also the associate dean for research at the University of Michigan School of Public Health. He is, of course, leading one of our major projects in Protect. The project deals with phthalate exposure and among women in Puerto Rico and looking into preterm birth. He holds a Bachelor of Science degree in industrial. Okay. From Iowa State University, as well as an MS and Doctor of Science degrees in environmental science and engineering and exposure and epidemiology and risk from Harvard University. He completed a postdoctoral fellowship in environmental and reproductive epidemiology, and his work on a wide range areas of research and has been part of many large-scale research projects. He's also an associate editor in Environmental Health Perspectives and serves on many reviews and industrial panels for EPA, NIH in recent years. Really excited to have John give the presentation today. So John, please go ahead.
Thank you, Akram. Hang on a sec while I pull up the presentation here. Okay, so here's my title slide. Hopefully everyone can see this. I will continue as if they can until I hear otherwise from Kristen. But welcome everybody. My name is John, as Akram said, and I'll be talking about environmental epidemiology today. So my objective is to present basic concepts and illustrative examples, both classic and contemporary, of environmental epidemiology for the non-epidemiologists. So this is the goal of the Protect Academy, is to introduce some of these concepts to the non-experts. So if you are an epidemiologist, you can either hang up now or just kind of relax. But a lot of this will be reviewed for you, but hopefully there are people here that this will add to their ability to be conversant in the area and interpret the studies that they come across in their own work. Here's a basic outline of what I'll talk about today. So I'll start with an introduction to the Protect program, which is sponsoring this event, and how it relates to what I'll be talking about. Then we'll go into some history, and then I'll go through the major types of studies. I won't touch on every single possible type of epidemiology studies, but I will talk about the major ones that you see, and I'll give examples of those and a description. I will also introduce some of the effect measures that are used in these types of designs that hopefully will be helpful as you come across these studies in your work. I'll touch on causality and study validity, which are extremely important concepts in the interpretation and the conduct of epidemiology studies. And I will close with a little bit more on the exposure assessment piece of epidemiology. So a brief word first about the Protect program. If anyone was on the first Protect Academy seminar on Monday, Ingrid did a nice job explaining. I just thought I'd cover this briefly again for those of you who were not there or are not familiar with Protect. But it stands for the Puerto Rico Testsite for Exploring Contamination Threats. And what it is it's a cross-disciplinary team that our main goal is to look at the association between environmental exposures and risk of preterm birth, specifically in Puerto Rico. And throughout my presentation today, as some of my examples, I will, some of the more contemporary examples, I'll bring some of the work we've done up till now that help justify why we're looking at preterm birth in Puerto Rico. They do have the highest rates of any jurisdiction in the US, as well as among the highest rates in the world. They also have quite a bit of environmental contamination on the island. In my particular project, what we're calling the Targeted Epidemiology Project, Project 1, my goal is to look at a broad range of exposures that may be associated with preterm birth. But in the short term, our primary hypothesis for this epidemiology study is exposure to phthalates. And for those of you that don't know, phthalates are a diverse group of chemicals used in various consumer products, PVC, plastics as a plasticizer, some personal care products, and the different types of phthalates are used in the different products. So they're ubiquitous in the environment, and there is some evidence for exposure in Puerto Rico, both through the household use or through potentially environmental contamination. So that's just one of the 5 studies is mine. The other ones that we're linking to are a Project 2, which is a reproductive toxicology study led by Rita Locke-Russo here at Michigan. And I'll touch on that a little bit more as I go through some of the pros and cons of epidemiology in relation to other scientific disciplines. Project 3 is a non-targeted chemical analysis led by Roger Giese, a biochemist at Northeastern. And that's taking a much broader approach to the exposure piece. We're utilizing some of the same cohorts and things, but he's able to do some very innovative stuff looking at specific exposures. We have projects 4 and 5 are on the environmental engineering side. You heard from Ingrid on Monday talking about fate and transport, and then Akram, who did the intro today and is the overall PI, is looking at remediation projects, specifically energy efficient or green remediation. We also are supported by several cores, data management and modeling core, and the other very important one for my project that I'll talk about today is the human subject and sampling core based at the University of Puerto Rico, led by Dr. Jose Cordero, who's a physician and epidemiologist there. So again, this is a cross-disciplinary approach, and we're putting on this Protect Academy to sort of facilitate the cooperation between the disciplines and to become conversant across disciplines so we can work together more effectively. Okay, so now epidemiology. So again, this is just one piece of our approach to the problem of Protect, but first a little background. So the origins of epidemiology have been traced to ancient Greek times with Hippocrates, who is known as the father of Western medicine. So he came to develop a lot of the current ways of thinking now, as opposed to what had been done up to that point, where disease was thought to be more of a supernatural phenomenon. He started bringing more of a scientific mind to it and started to track patterns of disease within the population, started thinking about how it could be useful to keep records of how diseases are showing up within the population. So that was a long time ago. Then many years went by, hundreds and hundreds of years went by until the next sort of figure in the development of the science of epidemiology came around, and his name was John Grant, a London haberdasher, which I had to look up this word. It's actually like a men's clothier or outfitter. So this was his profession was a haberdasher. His hobby, I guess, was looking at data and statistics. But he was looking at the mortality updates that they would put in the local paper every week, every month. I don't know how often it happened. I guess it says weekly here, but he started to look for patterns in that data as they would be published. Started looking at mortality rates and birth rates among subsets of the population, like males versus females and things like that. So it really started to organize the data that they were collecting. They didn't really use it to its fullest, obviously, but he started to figure out more ways that it could be useful and actually published a book titled there, The Natural and Political Observation Made Upon Bills of Mortality, which is credited with moving the field along. Another 100+ years went by, and a British surgeon and physician noted associations between occupation as a chimney sweep. So if you think about Mary Poppins, I think is the movie with the chimney sweep, but he did note an increased rate of scrotal cancer with that occupation, and if you could imagine, it's quite dirty. A lot of combustion products are involved. So one of the first real environmental epidemiology projects there. Moving on to the next century even, as the next landmark, and this is John Snow, who everyone who works in epidemiology is familiar with this name, but what he did was he built upon some of these concepts of moving more to a scientific framework to look at a specific problem of cholera in London in the 1800s. So they had these waves of death from time to time, and there was a lot of confusion and things as to why that was happening. Nobody could really get a grasp of the situation. This was before the germ theory, so they really were at a loss for how this was happening. So he took some of the stuff that had been done earlier, some of the people I mentioned on the previous slide, and had to take it a step further, because previously things were done on a population level, looking at prevalence or incidence of various things here and there. But to solve this problem, because the area in question was served by 3 different companies that distributed water to these locations using different sources, which may have been involved in the different sources of the disease, he actually had to go door to door and start mapping which house is using which supplier or which distribution system. So that sort of was a big landmark in the field of epidemiology, moving from the population level data to individual level data to really get more specific and determine what's going on. So he went door to door, started mapping and tabulating the data, who's getting the disease, who's dying from it, where are they getting their water from, and because it was complex in the 3 different distribution systems, this was the level of detail that was needed. And at the end of this, he was able to pinpoint the source, and the more historical significant story talks about this Broad Street pump handle, which was removed as a symbol of they've determined the source, and was considered a great public health victory. But basically using field epidemiology methods and statistics to determine that. So although the field of epidemiology up to this point was more along the lines of infectious agents, the turn of the 20th century and more after World War II, a lot of the focus has shifted to other chronic diseases, not necessarily infectious diseases. So another big landmark study obviously was the determination of the association between lung cancer and smoking. So Dahl and Hill, in their famous study, they were looking at lung cancer and other diseases in association with other things, and just happened to come across this really strong relationship with cigarette smoking and reported on it. And if it hadn't been for epidemiology, we might still, the landscape of smoking and smoking laws would look extremely different right now than it does today. So that was sort of a turning point, looking at more of the chronic diseases, and that's where a lot of the development in epidemiology in the past century has focused, is chronic diseases such as cancers, other things. I'll talk about pregnancy and birth outcomes, and other diseases and disorders. So that brings us to a definition of epidemiology. In the basic sense, it's the study of the relationship of various factors determining the frequency and distribution of diseases in a human population. So you might see different derivations of this definition, but this is basically what it comes down to. And a big distinction here is that the focus is on groups, communities, or populations, not individuals. So while I say we can collect data on individuals, we're not talking about risk at an individual level. We're talking about what is the risk among a population. How many incident cases might you expect in a population in relation to an exposure, rather than you're an individual, this is you will or will not develop this disease if you're exposed. It's more of a population-based estimate. And as I said, since about World War II, the focus has shifted, though not entirely. We still look at infectious diseases, but a lot of the methodology development has than around chronic diseases. And it's still considered a young science with new methods being developed all the time. More sophisticated field methods or statistical methods or applications are currently ongoing. There are many different uses for epidemiologic information. So on the broad level, you have just an assessment of a population's health, and that's how the field kind of got started. You have you're collecting this data over time, and it's very useful for a number of things. I mentioned that we're not talking about risk at the individual level, but it overall can help in the clinical counseling. So through epidemiology, we learned that smoking is a significant risk factor for lung cancer and other things. So at the clinical level, you can tell or advise patients that they should probably quit smoking. It will reduce their risk of certain things. And that's an extreme example, but there's many, many other examples where it's been used in that sense. Health services and health economics, where do you want to put your resources? A lot of those decisions can be based on data that was derived from epidemiology methods. And this last one I've underlined, and these are what we focus on a lot in environmental epidemiology. So there's many different types of epidemiology. There's, if it's based on a disease, if it's based on a methodology, things like that. So there's cancer epidemiology, reproductive epidemiology, or environmental epidemiology, infectious epidemiology. There's many, many different types. In environmental, we focus on a lot of these that I have listed under this last bullet. So identifying susceptible subgroups. So everyone might be exposed to the same air pollution in a town, but some individuals will be impacted more greatly in response to that same level of exposure than other people. We want to evaluate mechanisms of action, and this is important for a number of reasons. Most importantly, to reduce disease, whether that's through a therapeutic agent or treatment or prevention. Having knowledge on that mechanism of action is very important, and that's where we do a lot of crosstalk with the toxicology groups in what we do. It can be useful for setting research priorities, and I have in parentheses here hazard identification. So historically, for something like chemicals, we've relied on toxicology data to identify hazards. You do some screening when you have a new chemical and that sort of thing, but there may be limitations in that. Maybe the model isn't, an animal model isn't appropriate for a certain disease. Something like preterm birth, which we're studying in PROTECT, there's not very good animal models that exist for that. And if you think about some of the historical examples, I gave the one about smoking, asbestos might be another one where if the world were to have relied on experimental or animal data, those wouldn't have been identified. So I think it can go both ways. Toxicology obviously is very important for a lot of these same reasons. It's just if you have them working in parallel and together, it can be much more effective at catching things. So that can help set research priorities. Risk assessment. So hazard identification is one of the first steps in risk assessment, but then another component is dose response. So a lot of times, again, we rely on the animal or experimental models for dose response, but in a very well-designed epidemiology study, you can also have some data to contribute on dose response there. Inform prevention or remediation policies and strategies. So in contrast to this one I mentioned on mechanisms, which may be looking at treatment, here we're moving upstream. So in the example of PROTECT, if we do find that phthalates are associated with preterm birth, that will inform what INGRID does on patent transport. How are these chemicals moving through the environment? How are people being exposed? And that can also inform Akram Al-Shawabki, who is doing remediation. Maybe move that certain class or chemical up on the priority list. And then finally, you can test the effectiveness of a policy or strategy. So one example is they took lead out of gasoline several decades ago. How can you show that that was an effective policy move? We have exposure data showing biomarkers of exposure have gone down over the years, but is there a health marker or an epidemiologic marker that could help support that as well? And that's something that's very long-term. It's very difficult to do, but can be extremely powerful from a policy standpoint. Okay, so now we're moving on to the next portion of the talk, which is types of studies. And there are several different ways to classify or break up the different approaches within epidemiology. You have aspects such as manipulation of exposure shown here, or randomization. So if you're able to manipulate exposure and randomize, you can have an experimental study. So this might be something like a clinical trial where you want to try a new medication, and you can do some of these things. There's also the case where you can have a quasi-experimental study. But in the event where you cannot manipulate exposure and you can't really randomize, you have what's called an observational study. So within these designations, so experimental studies, I mentioned clinical trials. So these are extremely common in the medical field and pharmaceutical industry, where you have a treatment for disease, you have a group of people with the disease, you have different treatment regimens, and you can randomize that and follow them over time and see how they respond. And that's an experimental study. You're manipulating that exposure. You can control what they're getting. There's also community interventions. So some examples of this might be in the environmental setting. Could be putting fluoride in the water. That's a community level intervention to prevent cavities. And you can look at that. That's been documented in past decades. Now there's been increasing concern whether there might be other side effects to that, such as adverse neurodevelopment, which the science is still developing on that. Then you have something like field trials, which is very common in things like health behavior, but not as common in environmental epidemiology. So we're going to focus more on this second primary group, and this is why. Hopefully it's intuitive, but for a lot of these exposures we're interested in, we can't really knowingly expose people to those. There are examples of this happening in the earlier days of science, but these days it's not considered ethical to, if there's evidence or even an inkling that something might be harmful, you can't go and set up groups that are given an exposure. So we're left to rely on observing what's happening to do this ethically, trying to measure what's going on and look for a basis of a comparison in that manner rather than assigning it ourselves. So I'm going to focus more on the observational studies from here on out. So these can be further broken down into what I have here listed as descriptive studies or analytic studies. So some descriptive studies are things like a case study or case series, proportionate mortality studies, ecologic studies, sometimes also referred to as correlational studies, and then cross-sectional surveys. And I'll give examples of each in the following slides. Some examples of analytic studies, meaning they're more detailed, typically would have individual level data rather than population level data, are cross-sectional studies. You'll see I have cross-sectional listed here twice, and I'll try and justify that here in a minute. Then we have case control studies and cohort studies, which I'll talk about. And those can be either prospective or retrospective, meaning just the relationship between when things occurred and when the data is being collected. Is it going in present time moving forward, or is it going back in time? So first, let's go through some of these descriptive study examples. So a case study or a case series. So this is represents a major interface between the medical community and the epidemiologic community. You might, if you look in the medical literature, there's all kinds of very interesting cases historically, whether or not they're involved with environmental issues, but even within environmental medicine, you do see a lot of instances where a case study was where it started or was served as a hazard identification step, where either a rare disease was followed up on, or you have high exposure scenarios. But basically what's going on is you describe a patient or a group of patients that present with a rare disease or something the physician hasn't seen before, and then they do a detailed workup and describe what they found. And a lot of times what that does is it leads to more study, either toxicologically in the laboratory or an epidemiology study. And there's a lot of examples also of high exposure scenarios. So pesticide poisonings is a very common one, where they actually learn a lot about how the pesticide behaves in the body and what it does to humans, unfortunately, through this avenue of case studies as they occur. So a classic example of a case study or a case series is back in 1974, Creech and Johnson published this paper on angiosarcoma of the liver and manufacture of PVC, polyvinyl chloride resins. The reason they published this and the reason it led to other things was because it's a rare tumor, and it was a fairly small workforce, and they found 3 of these cases among the people working there. So they reported on these cases. It came out in the Journal of Occupational Medicine in 1974, and by later that same year and the following year, there were 2 follow-up studies that used different methodologies to that also sort of supported that evidence that the rates of this were statistically higher among these workers compared to other populations. And those 2 were using mortality studies, which we'll talk about next. Like I said, there's many examples out there in the medical journals of case studies. One that I thought was fairly unique that's more of a contemporary example was in Environmental Health Perspective a couple of years ago. This was a little bit different because it was nested within an ongoing epidemiology study. What they did was they had an individual with extremely high level of exposure to bisphenol A and followed and looked much more closely at that individual's data and followed up that case, looking at what unique things might be reportable or useful from that very high exposed case moving forward to inform how we might design future studies. So that's a more contemporary example. And that was in relation to infant neurobehavior. Okay, moving on to the next type of descriptive study. The proportional mortality studies is based, as the title might suggest, on completely on deceased individuals or subjects. And it's fairly simple in its design in that it's looking at the proportion of subjects who died from a specific or general cause of death who were exposed to something versus those who died and were not exposed. And what this produces is called the proportional mortality ratio, or the PMR, which is one of those effect estimates you might see in the literature as you're reading up on environmental agents and health. It's not considered a true measure of disease risk because it has there's some limitations to the comparison and things. But if done well, it does, like with a lot of these other descriptive studies that I'm talking about, serves as really good evidence to for hypothesis generation or to further a hypothesis into other types of study designs. Some other limitations is obviously it's based on death, so it's very much after the fact, relies on good data, good records. Going back in time, there may be limitations in what was recorded on death certificates as far as underlying diseases or secondary causes. But if you have access to good records and good data, it can be an inexpensive and relatively quick way to look at associations between an exposure and mortality. So these are quite common in occupational studies among large groups of workers or industries looking at various things. I mentioned the polyvinyl chloride workers previously. Another classic example here is cancer mortality among workers exposed to zinc chromate paint. So by now, a lot of people, most people except in IARC has designated that hexavalent chromium is a lung carcinogen. But back when this paper came out, that wasn't the case. This is one of the papers that really set that on track to be looked at more closely in relation to lung cancer. But this was looking at male aircraft painters and compared it to a reference population and looked at whether or not they're exposed to these zinc chromates, which is a form of hexavalent chromium. And for respiratory cancers, they found a proportion mortality ratio of 1.84. So for PMR, you're looking at the comparison is to 1. A PMR of 1 means no effect. The exposed is the same as the unexposed. Here it's above 1. So the other thing we would look at, I didn't feel I had time to really go into it today, but you want to look at the confidence intervals around this PMR or this effect estimate. If it includes 1, meaning say it says the confidence intervals are 0.9 to 2.8, if it does include 1, that probably wouldn't be considered statistically significant. If the confidence intervals do not include 1, say it goes from 1.84, then it's at 1.1 to 2.5, that would be considered statistically significant. So that's another detail I didn't want to go into in too much detail today, but it is a very important aspect to these studies to think about the probability of chance. And the cancer-specific mortality ratio was 1.46 in this case. So again, the proportional mortality studies are very common in the occupational epidemiology literature. Moving on to the next type of descriptive study, ecologic. I've also seen it called correlational studies. But the main difference here is a lot of the other studies I'm talking about, the data is collected at the individual level. In these ecologic studies, the data is at the population level. And then the comparisons are made at that point. So there's a number of strengths and weaknesses to this approach. A strength is it can be done if there's population level data is available. It can be done quickly and inexpensively if that data is already being collected. But then on the flip side, there could be a lot of alternate explanations if you don't have detailed data on the individuals in the study. So again, as with the other types of descriptive studies I'm talking about, it really is good for hypothesis generation or furthering hypotheses. But you probably want to use more than just this one type of approach to look at an issue. And again, this is done at the population level, so I'll give one of the primary examples in environmental epidemiology is the Harvard 6-city study. So this is a paper that came out in 1993 in the New England Journal of Medicine. And what they did here is they had air pollution measurements over time from 6 different cities in the U.S. And then they coupled with that data on mortality over that same period. So you see these years they collected the data, and then they have the the air pollution by the city here. So you can see Steubenville had the highest pollution for all these different types of air pollution. You have total particles, fine particles, sulfate particles, and Portage was down there towards the bottom end, as well as Topeka. And if you overlay that with what they saw from survival or mortality, you see that Steubenville, who had the highest pollution levels, had the lowest survival or worse mortality outcomes versus Topeka and Portage. So this is at that population level. They're making this comparison of people are dying younger in these cities. They're more polluted. They were able to adjust for some potential confounders, but concluding that there is an association there. But again, as an ecologic study, there may be a number of alternate explanations that you'll want to consider in your interpretation. So that's ecologic studies. The final type of descriptive study is the cross-sectional survey. So this is where, a picture of a camera here, this is a snapshot in time. You have measures of your exposure of interest and the outcome of interest, or one or the other, and do what you can with that data at that point. Again, you can't really determine cause and effect, but you can determine associations or correlations between those variables. And I sort of included this both as a descriptive and an analytic approach because there's differing levels of detail that they go into. So on the survey level, or more of a descriptive level, I thought my example was next. But here's one example of how an effect measure might be looked at. So this is disease prevalence. Basically, it's in a population, how many have the disease. This is a cross-sectional example in contrast to a follow-up or longitudinal example where you'd have incidence instead of prevalence, where you have a time component to that. So that's the main difference there. So this is I show this because it's an introduction to the 2x2 table, as it's called. So you have 2x2, meaning that you divide your exposed and your non-exposed. That's one of the sets of two, and then your disease and no disease. That's your other set of two, and these are then what you use to calculate some of these effect estimates that I'll be talking about. So this is just a basic prevalence. But back to cross-sectional surveys. Here's an example relevant to our Protect program. So the National Vital Statistics Program, they collect information on births and deaths and when babies were born, including preterm birth and things like birth weight. But if you look at the preterm birth data, so this is percentage of preterm births by year. If you were to take just a single location in a single year, that's a cross-sectional survey. But when you compile multiple ones of these annual surveys, you start to get a longitudinal picture, which can be very informative. So in this case, for example, in 2005, we can tell that the rates of preterm birth almost doubled in Puerto Rico by using this cross-sectional approach. On the other hand, you can compare different populations. Say you only had data from 1990, you can say, okay, Puerto Rico and the US were virtually the same in that year. However, if you have data from 2005 and say, okay, Puerto Rico's at about 20%, US is about 12%. They're going up over the years in both cases, but for some reason, it's much greater increase in Puerto Rico. So this is one of those examples that I felt was a good example of cross-sectional use of cross-sectional surveys, but also serves as one of the examples of why our Protect program is looking at environmental predictors of preterm birth in Puerto Rico specifically, because our colleague Jose Cordero had data on other factors. So you could do a lot of ecologic type studies here, which they looked at things like what was the smoking prevalence in 1990 versus 2005 in Puerto Rico. It's actually gone down. What about maternal education? It's actually improved over this time. What about prenatal care? That also has improved over this time period. So some of those ecologic comparisons aren't really giving many clues to what is explaining this trend. So we're looking into environmental factors. Another more detailed, and I would maybe classify this as analytic rather than descriptive, even though it is cross-sectional, example is we looked at the US NHANES data. So this is the National Health and Nutrition Examination Survey. They do it in 2-year cycles. They've been doing it for over a decade now. And they include some biomarkers of exposure. And we were able to utilize that data to look at exposure to phthalates or phthalate metabolites measured in urine. And we, in this instance, we're looking at markers of oxidative stress and inflammation that were measured in blood from the same people, cross-sectionally. So these people reported to a mobile lab. They collected a urine sample and a blood sample at the same time. The blood samples were analyzed for oxidative stress and inflammation markers, among many, many other things. They collect demographic data, other things, anthropometric data, and the urine samples were measured for phthalate metabolites, among many other things. But because oxidative stress and inflammation are thought to potentially play a role in a lot of things, including preterm birth, we thought this was a way to, again, hypothesis generation, or furthering our hypothesis that phthalates may be in that, may be a contributor to preterm birth risk. And we saw significant declines in bilirubin, which is a decline in bilirubin is thought to potentially be a marker for increased oxidative stress, as are increased alkaline phosphatase and change in absolute neutrophil count. So again, this is just an illustrative example of a cross-sectional study, a little bit more detailed than some of the other surveys cross-sectionally that are done. But again, because they were collected at the same point in time, we can't rule out that for some reason people with higher oxidative stress are excreting increased amounts of metabolites, for example. So again, we want to rely on multiple ways of looking at an issue. through multiple study designs. So that brings us to the analytic studies. And this is where we get more detailed information at the individual level, and we can start to add to that causation or cause and effect storyline. So the first example of an analytic study is the case control study. So this is where cases are selected from a source population, and then controls from that same source population are randomly selected. And once you've defined your cases and controls on the disease status, then you go back and try to determine what their exposure was. So you're starting at disease and then going back and trying to define exposure, and then you can calculate what's called the exposure odds ratio, which is an estimate of risk of the disease in relation to exposure. And these are typically considered retrospective because if you're starting with disease, our causation model says, okay, the exposure had to take place before that. So you usually have to go back in time, although there are certain instances where the data could be collected in a way that's considered prospective. And a lot of times, just a side note here, a lot of times people mistakenly interchange the words retrospective and prospective to describe case control and cohort studies, respectively. But you can have, for example, a retrospective cohort study. So that's actually not completely accurate to do that. So here, again, we're starting with disease. We're going back and trying to define exposure. Again, very common in occupational studies. One reason for that is because if you're able to define exposure well based on something like a job description, you can get a good estimate of exposure. However, in environmental epidemiology, a lot of times it's very difficult to go back in time and define exposure unless you have information on geographic differences, archive samples, historical data on exposure, things like that. So again, a specific study approach is going to depend on a lot of things. Things like what kind of data do you have access to? Well, what's the question, first of all? What kind of data do you have access to? What sort of budget do you have? All these considerations go into how you're going to go about conducting a study. So that's a case control study. So some of the advantages of case control studies is they can be quicker if you have good data because the disease has already occurred versus following prospectively something like cancer that can take decades to develop. That's a really long-term study, whereas here you're starting with disease. Another advantage is it's much more cost efficient for rare diseases. So if you have 1,000 people and the risk of a certain disease is only 1 in 1,000, you might do the best designed prospective study ever, but if you only have one case to go on, you're not going to be able to do much. So for rare diseases, it's a much more efficient way to do things with the case control. Because you'd have to have extremely large studies, which can be very expensive to do a cohort study. So I mentioned the odds ratio. Here's our 2x2 table. What is an odds ratio? It's basically solves out, this is the simplified solve form to A times D divided by B times C. Basically, it's just the prevalence of disease of the exposed versus the non-exposed. And you get, in this case, we had an odds ratio of 5.2, which would be interpreted as exposed individuals had 5 times the odds of developing the disease compared to unexposed, because it is on the multiplicative scale. So an odds ratio of 5 is quite rare. It's very that's a very high odds ratio typically. So a classic example from the occupational literature again. This is a New England Journal of Medicine paper looking at nurses exposed to anti-neoplastic drugs. Those are cancer drugs. They're cytotoxic by design, so people who aren't supposed to be exposed who are exposed, you could have some adverse effects. And in this case, they did see an increased exposure odds ratio in relation to nurses who self-reported being exposed to these at work in relation to fetal loss. So this again served as, this is a topic that's still high on the priority list, at least for NIOSH, for occupational exposures. even today, and this study came out in 1985. So a lot of these are sort of long-term hazard identification, and then it takes a lot of time, effort, money, and follow-up to get a better idea of what that risk might actually be. A more contemporary example, back to something Protect related. We did a study a couple years ago in preparation for Protect, and what we did was we selected 30 preterm birth cases and 30 randomly selected controls from an ongoing cohort study in Mexico City, led by our former department chair, Howard Hu, that had been following up pregnant women and children in Mexico City for almost 2 decades now. But they had a large archive of samples and data that we were able to look at to do this in a small case control study. So we went back to the freezers and we took 3rd trimester urine samples from both groups and had them analyzed for the phthalate metabolites. And we did find, we calculated our odds ratios. These were adjusted for things like age and pre-pregnancy BMI, et cetera. And we looked at above versus below the median level of these metabolites, and we found increased odds of preterm birth in relation to a number of these phthalate metabolites. Again, it was a very small study, so again, more for furthering our hypothesis rather than a be-all, end-all in the evidence of phthalates in preterm birth. Okay, so that was case control studies. I mentioned some of the advantages. Some of the disadvantages is exposure assessment can be challenging in a case control study if you don't have historical data. Sometimes it's just not possible to go back and determine what people's exposure is. So, for example, we're looking at phthalates. If you had any particular population, you want to say what was their exposure to phthalates 20 years ago, it's going to be, I'm not sure you could do it unless you had archived biological samples, because there's no validated questionnaires and things like that would help, unless you had some sort of environmental spill or contamination issue. It would be difficult. Okay, so moving on to cohort studies. So this is compared to a case control where you start with disease and go back and look at exposure. Here with a cohort study, you're starting with exposure and then you look for disease. So you look at a population that's free of the disease or outcome of interest and have a range of exposures. You don't want everyone in your study to have the same exposure, because then you'd have no basis of comparison. But you then follow them forward and try to, you then are able to assess exposure moving forward, and then you look for the disease to develop. And then you're able to calculate the risk of that disease in relation to the exposure. So there's many different types of cohort studies. There's prospective, there's retrospective, there's other subdivisions of cohort studies. There's also ones that are based on time, which you'd have person time of follow-up versus something like a pregnancy study where that's not as relevant. So you'd have different effect estimates or types of effect estimates calculated for those. But because this is going longitudinally, and you can show that your exposure preceded the disease, this is typically considered the best study getting you toward that cause and effect relationship or causality. It's still not perfect compared to an experimental study where you can manipulate exposure, but it's as close as we can get in epidemiology to that. So that's one of the main advantages to a cohort study. Another one is you can define exposure much better in a lot of instances compared to a case control, because you're able to do it currently or moving forward rather than trying to piece it together in the past. Downsides are, again, cost, especially if it's a rare disease. You'd have to have an extremely large population that you're following and spending money on to follow in order to be able to conclude anything at the end of it. So there are pros and cons to the various types of study, and the particular approach will depend on the situation at hand. So one type of effect estimate is the incident rate ratio. So this is for the types of studies where you have follow-up time as part of your denominator or incidence. And this is just an example. Again, I don't expect people to come out of this seminar knowing how to run these calculations or conduct their own study, but hopefully give you a better idea of what some of these things mean if you see them in the literature. This is an example of an incident rate ratio. Just notice the 2x2 table changed slightly from no disease as your other column to person time. That changes the calculation and the interpretation slightly. Looking at incidence rather than prevalence. However, for something like birth outcomes that we're looking at, we don't have that time component, so we're probably looking at calculating something like a relative risk, which is similar to an odds ratio, but it is calculated out of this 2x2 table. Again, has exposed, not exposed, disease, no disease, and here's calculation down here. And there's a lot of intricacies as far as what it means versus the odds ratio and things that I won't get into, but it is a good estimator of risk, the relative risk here. Okay, so a classic example of a cohort study. I mentioned some other ones, but here is asbestos exposure, another one of those things that epidemiology really played a role in, or a success story for epidemiology. Back in 1964, they had a cohort of exposed workers that they followed. In this case, they didn't have an unexposed work population. They just used a comparison group of U.S. males. And in this case, instead of an incidence rate ratio, they did calculate the standardized mortality ratio, which is a little bit different and sort of a hybrid between a proportionate mortality ratio and a cohort study. But again, it's one of those classic examples where they started with exposure, followed them over time, and found increased risk in relation to exposure that really served to change the face of public health and specifically occupational health in this instance. And of course, asbestos is still a big deal these days. Talking about different types of asbestos, different scenarios, lower levels, environmental levels, are those toxicologically relevant? Another example is what we're doing now in Protect. So this is just a schematic of the type of information we're collecting. We are recruiting pregnant women early in pregnancy in Puerto Rico through a recruitment strategy. And then once they sign informed consent, we have a first visit between 16 and 20 weeks where we do a detailed interview. We abstract their medical records. We collect a range of biological samples and have them fill out other questionnaires such as product use, again, because things like phthalates may be related to that. So we have quite a bit of information and samples being collected there. And we do a second visit in their home where we collect environmental samples as well, looking at tap water and things. So trying to look at the whole spectrum of exposures. We collect more interview data, more product use data, things like that. Then we have another visit, 24 to 28 weeks, where we do another round of all this data collection. And what this can do is help us look for, not only does it give us a better average of something like phthalate exposure, which can vary quite a bit from time to time within a pregnancy, but also may enable us to look at sensitive periods of exposure within pregnancy. And then at delivery, we collect relevant data as our outcome. And then moving forward, we hope in the future to continue following up this cohort as the children develop. We can answer many, many other questions moving forward. So that's cohort studies. So just briefly, a few other things to consider. So these, back in 1965, Austin Bradford Hill published what then became known as the Hill criteria, that some people probably mistakenly think of as criteria for causality. A lot of people are now rightfully saying that these are more considerations. You can't just go through this as a checklist. These are just all things you want to think about as you look at evidence. So you want to look at the strength of the association, the consistency between populations, the specificity, which is much easier for things like a specific lung disease that can be tied to a specific agent, But for things that we're studying now that have many, many different causes, it gets more difficult to satisfy this one. Temporality, again, the exposure occurring before the disease. Biologic gradient, this is talking about dose response. But again, this one is becoming more challenged, especially in the endocrine disruption field, that the dose response curves may not be as you might expect. Plausibility. These next three actually all relate to more of that link that we're trying to strengthen and protect between epidemiology and animal or experimental data. Biological plausibility, coherence in different models, and then experimental evidence. All those three sort of relate to that biological mechanism piece. Does it make sense? Is it coherent with what is known about the progression of that disease historically in its natural history? And are there animal or other experimental models that support it? And then finally, analogy. If you have an agent that's like another agent or chemical, and that chemical has been shown to cause something, that's what's meant by analogy. So again, these are just considerations. I wouldn't consider this to be a checklist of needs for a study, but just things to think about as you interpret results from a particular study. So another thing you want to consider when interpreting studies is bias, error, and precision. So as an epidemiologist, the goal is to eliminate or minimize bias and error through the design of a high-quality study. And things we consider are confounding bias or confounders. And I'll have a single slide on each of these. Selection bias and information bias. And then different types of error. Is the error random or is it systematic? That's a very important distinction. As systematic error can be a showstopper because that might really inflate effect estimates, for example. Whereas random error might just hinder your ability to see a true association. So just a brief word about confounding. This is defined as the confusion of effects of interest by another factor. So there's three necessary characteristics for a confounder, but just because a variable fits all these does not necessarily make it a confounder in a specific situation. So it's sort of a case-by-case thing. But the variable must be an extraneous risk factor for the disease in question. It must also be associated with the exposure under study, and it cannot be in that causal pathway. So those are the three characteristics that are necessary. So I just thought of a recent example. We did a recent analysis looking at PCB exposure among men and low testosterone. So we might see an association that is quite strong if we don't consider other factors. But age is known to be a very strong factor in having increased PCB concentrations, at least for the persistent congeners in your blood, and also increased age is associated clearly with lower testosterone. So if we were not to take into account age, that association could very well be confounded by age. So this is sort of one of the classic example I could think of. Most of them are not this straightforward, and some of these diagrams can get quite complicated, but I thought this might be an illustrative example of one potential source of confounding in one association. Selection bias, of course, if you're not selecting your participants in an epidemiology study in the right way, it can lead to problems. So this is if the exposed and unexposed populations are not truly comparable, but more specifically, if their selection is dependent on both the exposure and disease in a way that could lead to increased or decreased artificially effect estimates. That's what you want to avoid. So something like if you just put out an ad for a study and you get people volunteering, you have to think about why are they volunteering? Is it related to the disease status and exposure? If so, that might result in biased estimates. Surveillance, admission, diagnostic things, clinical studies, a lot of times are getting populations based on people that come to a hospital, for example. Even control populations, if they don't have the same disease, you want to think about possibilities for this bias. A well-known one in occupational studies is healthy worker effect, in that these proportional mortality ratios are a lot of times less than 1 for occupational populations because the people out there working tend to be healthier than the average overall population. So you have to try to account for this as you conduct some of these studies. So just by being in the workforce, that automatically means they're lower risk for certain things. And then attrition bias, you get a lot of loss to follow-up that can result in later on selection bias. Information bias, again, this is where information is gathered in a way that's not consistent, but also that's related to both the exposure and the outcome. So a common one is recall bias. Case control studies, another limitation is people with the disease may be more likely or less likely to remember exposure or recall exposure. So if they're distraught over having been diagnosed with something, you ask them, were you exposed to solvents? They might remember more clearly or be more likely to say yes than a control group. Smoking in pregnancy is another one that is tough to get good information on because it's known not to be healthy, so people may not report accurately. Observation bias, you need to make sure interviewers do not know disease status when they're conducting interviews, or people doing the records, you want that to be blinded. Again, loss to follow-up can lead to information bias. And then we have measurement error and misclassification bias, which I touched on earlier. And just a quick example here is that random misclassification or random error can really hinder your ability to see a true effect. So here this is a scenario that was run in a study. The relative risk was 2, truly, and then sensitivity and specificity for that yes or no exposure variable was tinkered with a little bit. And you see that these relative risks can really be harmed, especially in this case, depending on how that sensitivity and specificity of that exposure variable, how sensitive and specific it is in that scenario, can really make a huge difference. And we're still, all these are above 0.9. In reality, you might see sensitivity that's much, much lower than that. All right, I'm running out of time, so just briefly on exposure assessment. My main goal here was to just hit home the fact that exposure assessment is many times the primary limitation to an environmental epidemiology study for the reason I just said. It doesn't take much error in that exposure to really throw off a study. So you want to think about what's the magnitude, frequency, and duration of that exposure, but also the timing in relation to your outcome of interest. What's the parameter that's most relevant? Are you looking at cumulative, average, peak exposures? All these different parameters may be important for different reasons. And then also exposure versus dose versus biologically effective dose, sorry, is also a very important consideration. So here we have a source of an exposure. We have our fate and transport that Ingrid was talking about on Monday. Then you have the person here that's exposed. Then that agent goes through some metabolism, some distribution, and then you have a disease. So you could try and, up until here, try to define exposure at any place on this spectrum. The closer you get to disease, the more accurate it's going to be in that relationship. However, the downside of that is you're further removed from the source. So if you have a measure here, you might not be able to determine where it's coming from. So from a risk management standpoint, that could be a challenge. But if if all you have is a source or an emission, and you're using that to try to come up with a relationship over here, you might have a lot going on between the two that add in that misclassification or that error that will really challenge that association. And then, I'm sitting in a room with a bunch of toxicologists, so I don't need to go over this in much detail, but you have a lot of things that can happen between the external, the environment external to the person and its effect, the relative amounts of a biologically active portion of that original exposure can change quite a bit from step to step. So again, a lot of chances for error to be introduced here. Starting to close up here, in the interest of time, I'll just go through this very briefly, but here's some of the different types of approaches for exposure assessment. So it's going to depend on the type of study. Are you looking prospectively, or can you measure current exposure in a prospective study? If so, you have a lot of different options you can go with. You can go with questionnaires and diaries, which are cheap, but the value of information might be low. You have environmental level monitoring and even GIS mapping you could do. You could look at personal monitoring. This is like an air monitor they might wear 24 hours a day to get at what they're actually breathing. that can be quite labor-intensive and expensive. Or one of the big things we're doing in Protect is biomarkers of exposure. So when you have a prospective study, you have a lot of options. Once you get to the retrospective, you're relying primarily on indirect methods, unless you have really good historical exposure data for some reason, which might be a rare instance. But you're relying on various things. Then you have exposure models that you could build to try and predict that exposure. This scenario over here for future, that's usually more for risk screening or risk assessment. I won't go into that right now. But this slide is just to show there's many different options. It can depend on, again, what type of study it is and what sorts of data do you have access to, among other aspects. That last slide, I think, this is just a hierarchy of exposures approaches. So this is not, there are exceptions to every rule here. In some cases, some of these that are listed low that might be more your geographically based. In some studies, that's going to be better than an individual level biomarker for a number of reasons, or even a questionnaire, something like secondhand tobacco smoke. If you have a biological marker of secondhand smoke, it might only reflect exposure from the past day, whereas if somebody knows they were exposed for the past 9 months of pregnancy and are able to report that to you, that might be a better measure in that instance. But for the most part, biomarkers are considered accurate, though, again, you want to think about all the considerations there, the toxicokinetics and what it means, and all the aspects of any of these types of measurements in a study. Okay, so in summary, hopefully you were now have a better idea of the different types of epidemiology studies out there and some of the pros and cons. The most important factor of a study is the quality of the data. All these different approaches have their strengths and weaknesses, their pros and cons, the scenarios where they're desirable or maybe less desirable. But it's up to us to critically assess the design, the methods, the reporting of the results, the interpretation. If those are out there clearly, then we can start to paint a picture. Because it's hard to believe just a single epidemiology study, because there is no such thing as a perfect study. There's always limitations, and that's why we like to see different studies, different designs, different populations that look at the same issue to put together more of a picture of what's going on rather than relying on a single study. And then you add in the animal or experimental data, and you can get an even better picture of risk. And then finally, exposure assessment. Hopefully, I had to rush through it a little bit, but hopefully you gain a bit more appreciation for the importance of exposure assessment in epidemiology. Okay, I apologize I had to rush there at the end, but I guess it's open for questions if there's anybody left.
Thank you, John. Thank you, John. I had one question so far that came in from online. It came in earlier in your presentation, so it's going back a ways, but it was asking whether or not epidemiology only refers to human health or if it can apply to other species, such as, study of white nose fungus in bats.
That's a really good question. Historically, it's been thought to be refer to humans as the rise of epidemics and the study of epidemics, but I've seen recently the same techniques and methodologies applied to things like household pets, livestock, populations like that. So certainly you can use a lot of the same approaches, and even I would call it epidemiology, yeah, for other species.
Thank you. Any other questions outside? I have nothing through the chat feature. If someone has a question but doesn't know how to use the chat feature, you can raise your hand. You can raise the hand function as well, which is right near the microphone next to your name on our participant list. And at this point, I'm still not seeing any questions. So, John, I think that's great. We appreciate you doing this. I want to let everyone online know that we have our next Protect Academy seminar coming up on Monday, which is the 17th, and that will be toxicology, presented by Dr. Rita Locke-Caruso, also at the University of Michigan. And we hope you will join us for that if you're interested in the topic. And thank you all for attending.
Thank you.
Thank you. Bye-bye.